Good evening, everyone. This is Dr. Shruthi HR, Assistant Professor of Department of Anaesthesiology, Mysore Medical College. To begin with, I would like to thank the organizers, especially Dr. Bala Bhaskar sir and Dr. Josna ma'am, for giving me this opportunity to speak in this VAA forum in front of my staff and my seniors who have taught me the ABCD of anesthesia. I hope I live up to their expectations. Coming to the topic for today, my topic is like coronary circulation and anesthesia. I'll be mainly talking about the anatomy and physiology of the coronary circulation and a little bit of the pathophysiology of coronary circulation. Why do we need to know about the anatomy, physiology, and pathophysiology when we have come to anesthesia? If it's bothering you, I would like to tell you that these days we have been hearing a lot of middle-aged people ranging from 30 to 50 years who are succumbing to sudden cardiac arrest while doing simple exercises or hitting a gym or while delivering a lecture and all. When investigated, it showed that either they had a severe massive MI or a failing heart and or an arrhythmia, which indicated most of them had a coronary circulation block, where there was a block in their coronary arteries. Since the incidences of the coronary artery diseases have been increasing these days in young middle-aged people, it becomes important to know about the basic anatomy and physiology and pathophysiology, because we encounter many middle-aged people coming in for surgeries day in and day out, and we need to keep anesthetizing such patients. So it's better we know about it so that it helps us in maintaining an adequate perioperative coronary flow in order to avoid the perioperative cardiac events. Coming to the anatomy, it mainly heart is supplied by the left and the right coronary arteries. They branch directly from aorta. The left coronary artery, after branching from aorta, gives rise to the left anterior descending artery, which through its diagonal branches supply the septum and the anterior wall of the left ventricle. Whereas it also gives a left circumflex branch, which runs in the AV groove, giving the marginal branches, which supplies the free wall of or the lateral wall of the left ventricle. The right coronary artery supplies the right ventricle through the marginal branches. And also in 85% of the patients, people, it gives rise to the posterior descending artery, which supplies the posterior and the inferior wall of the left ventricle. Around in 15% of the individuals, the posterior descending artery arises from the left coronary artery. And as a result, we decide the dominance of a person based on from where the posterior descending artery arises from. So most of us, like 85% of us, are right dominant, which means that it arises from the right coronary artery, and 8% is left dominant, and around 7% is codominant. Coming to the venous drainage, about 85% of the venous drainage of the coronary circulation is into the coronary sinus, which empties into the right atrium, whereas 15% directly through the Thebesian veins drain into the right atrium, whereas the right ventricle drains into the right atrium through the anterior cardiac veins. Whenever the heart is at rest, it receives around 5% of the total cardiac output, that is around 250 to 275 ml per minute of blood flow, whereas the oxygen consumption is around 10% of the total body oxygen consumption, that is around 25 ml per minute. Whenever the heart is exposed to stress or exercise, the cardiac output and the oxygen requirement, the demand increases 4-fold to 7-fold. In order to meet that, the coronary blood flow also increases the 3-fold to 4-fold. When we talk about heart at rest or exercise, the most important thing is the equation between the supply and the demand. Whenever there is an increase in demand, such as in cases like increased heart rate, contractility, or ventricular wall tension, the supply has to be met, has to increase in order to meet the demand, in order to maintain that balance between the supply and the demand. In this flow chart depicted here, we see that when oxygen carrying capacity, things like FiO2, hemoglobin, and iron content are kept constant, the only way in order to meet the demand is by increasing the coronary flow. Coronary flow has two components in the flow chart. One is the diastolic flow and the resistances of the blood vessels. Diastolic flow, we all know that most of the blood supply to the cardiac is during the diastole. So diastolic time is very important. I'll talk to about it in later slides. And even again about the resistances offered by the vessel tone, like epicardial, precapillary, or microvascular resistances. It depends on the various factors which we'll be discussing a little later. Here we know that the myocardial oxygen extraction is around 70 to 80% at rest. So whenever the heart is exposed to any stress or increased demand, the further extraction of oxygen is little difficult. So in order to meet the demand, there has to be a increased coronary blood flow. When such mismatch occurs between the supply and the demand, it can affect the cardiac function and it can lead to cardiac events. This equation is mainly maintained or kept in check by two physiological entities. One is the coronary perfusion pressure and the other one is the coronary autoregulation. Coronary perfusion pressure is that pressure gradient that drives forward the coronary flow for the myocardial perfusion. It is given by the formula arterial diastolic blood pressure minus left ventricular end diastolic pressure. In this chart, we can see that the aortic or the arterial blood pressure is around 120 during systole and 80 during diastole, whereas the left ventricular pressure is around 121 during systole and 0 during diastole, and right ventricular 25 during systole and 0 during diastole. It's very clear from the table that there is a pressure difference between the aorta and the left ventricle, mainly during the diastole. Like there's no pressure difference between aorta and left ventricle during systole. Whereas the pressure difference between the aorta and the right ventricle is there both during systole and diastole, which says that the right ventricle receives blood flow both during the systole and diastole, whereas the left ventricle receives almost 99% of its blood during the diastole. Another important thing is that coronary autoregulation. It is the capacity of the heart to maintain steady myocardial perfusion across a range of perfusion pressures when the oxygen consumption are kept constant. From the diagram on the right side, we can see that over a range of 60 to 140 mm of coronary perfusion, pressure, there is an autoregulatory range, that is the 60 to 140 millimeters of mercury. The coronary flow is kept constant. But beyond that, whenever the pressure falls below 40 millimeters of mercury, as in cases of cardiogenic shock or severe hypotension, there is a drastic fall in the coronary blood flow. And the most common area or the myocardium which is affected is the subendocardial region, because it receives most of its blood during the diastole. As the pressure comes down, the perfusion of it is affected. The main factor which makes this coronary autoregulation possible is the coronary vascular resistance. That is the vascular tone. The coronary flow during the circulation in the coronary blood vessels follows the Hagen-Poiseuille's law. It states that the flow rate is proportional to the fourth power of the radius. In this equation, we can see that when pressure, viscosity, and the length is kept constant, it is proportional to the fourth power of the radius. It shows that there is an enormous influence of the vessel diameter, or which is maintained by the vascular tone, has on the blood flow through the vessel. Actually, what controls the vascular tone? There are many factors which influences the vascular tone. That is metabolic, endothelial, myogenic, neural, or physical factors. Coming in detail about each, most important being the metabolic control. Here, we know that the coronary circulation is extremely sensitive to the myocardial tissue oxygen tension. So whenever there is a decreased oxygen tension, such as cases like ischemia or hypoxia or hypotension, there is increased adenosine release in the tissues, which causes activation of cyclic AMP and potassium ATP channels activation, which causes decrease in intracellular calcium, and as a result it causes vasodilatation. Coming to the endothelial control, the vascular endothelium actually modulates the contractile activity of the underlying smooth muscles. Basically, it releases nitric oxide, endothelial-derived relaxing factors, prostacyclins, and bradykinin, which mainly cause the vasodilation and keep the vessels open. Whereas whenever there is an endothelial injury or a microvascular injury, it tends to release endothelin and thromboxane too, which are the potent vasoconstrictors, which cause vasoconstriction and proliferation, leading to clots or clots. Coming to the myogenic control, it's also called as the Baylis effect. It was discovered by Sir William Baylis in 1902. It shows that whenever there is a distension of blood vessels by the increase in the pressure inside the blood vessels because of the increased flow, it causes a reflex vasoconstriction or myogenic constriction causing vasoconstriction, which is mainly monitored by the stretch receptors which are present in the vessel walls. Um, Even again, the blood vessels are under the neural control. It's like sympathetic and parasympathetic. They control either directly through the receptors or indirect effect also is there. The directly sympathetic control is through alpha and beta receptors. Receptors mainly cause vasoconstriction, whereas beta cause vasodilatation. And parasympathetic is through acetylcholine muscarinic receptors, which cause vasodilatation. This also has an indirect effect through the sympathetic stimulation, which increases heart rate, contractility, and increased metabolism and requirement of oxygen, which in turn causes vasodilatation. Coming to the extravascular compression, we know that the blood vessels which enter the myocardium run perpendicularly into the myocardium till the endocardium to form the subendocardial plexus. They go directly between the muscles into the subendocardial region perpendicularly. So whenever these ventricles contract during the volumetric contraction, these blood vessels which run perpendicular gets compressed, and as a result, there won't be any flow through those vessels. So the diagram on the right side shows that there is a sharp decrease in the flow during the volumetric contraction of the ventricle during the systole, whereas when the ventricles relax during the diastole, the maximum flow is during the early diastole. Other physical factors which has influence on the coronary flow is like the aortic blood pressure, heart rate, cardiac output, and the ventricular wall tension, which increase the demand and in turn increase the blood flow. Coming to effects of anesthesia on coronary blood flow, most volatile anesthetic agents are the coronary vasodilators. Either they act by direct vasodilating properties or by reduction in the myocardial metabolic requirements or by indirectly by the effects on the arterial blood pressure. Halogenated anesthetic agents, they activate ATP sensitive potassium channels and they lower the intracellular calcium. They have a negative inotropic effect and they also reduce the oxygen requirements and prevent reperfusion injury. Hence, they are beneficial in myocardial ischemia. I would like to add on a special note on coronary steal phenomenon, which is caused by the isoflurane. In isoflurane, arterioles dilate more than the epicardial vessels. So, whenever we know that there is occlusion in the vessel, there is a flow distal to it is stopped, and the area which is perfused by the vessel distal to the occlusion is hypoperfused, and whereas the surrounding areas are hyperperfused because there is a blood which is directed towards the normal tissues. Whereas whenever if you use a vasodilator in cases of coronary artery disease, like whenever there is a block, there is further vasodilatation of the vessels which are supplying the normal surrounding tissues, in turn stealing the blood vessels from the ischemic area to the normal area. This is called as the coronary steal. It says that isoflurane causes a detrimental redistribution of the coronary blood flow away from the ischemic myocardium, especially when there is hypotension. Coming to the central neuroaxial blockade or thoracic epidural blocks, these all cause sympathetic blockade, so thus reduce incidence of tachycardia, hypertension, myocardial oxygen demand, and so indirectly decrease the blood flow. We now know how a normal heart functions under stress. Being an anesthetist, for us, most of the patients we encounter have stress of going under the knife or stress induced by intubation response or regional block or subarachnoid block or anything. Normal heart can usually take the stress either by increasing the blood flow or decreasing the blood flow during the, over the autoregulatory range. But what if there is some block in the coronary circulation? So here comes a few pathological conditions such as coronary artery diseases, termed as coronary artery diseases. It can be because of atherosclerotic change or a thrombus or a coronary spasm. But before going into this, I would like to mention a little bit about the um, coronary flow reserve. This is defined as a ratio of the maximal or the hyperemic flow down a coronary vessel to the resting flow. It says that normally, normal individuals, it's around 3 to 5, which means that whenever there is a demand, coronary flow can increase 3 to 5 times in order to meet the demand. It's a measure of the entire coronary circulation. Whereas whenever the coronary flow reserve falls below 2, it indicates epicardial coronary artery disease or the microvascular dysfunction. Coming to the atherosclerosis. Atherosclerosis is a slow progressive disease characterized by deposition of fibrin, calcium, cholesterol, fatty substances within the inner lining of the blood vessel, causing a plaque and occluding the lumen of the vessel. Since it's a chronic disease, our heart adapts to it over time by developing what we call as the collaterals. It's the beauty of the nature to adapt. But with such progressive coronary stenosis also, the baseline flow remains normal until 80 to 85% of the diameter reduces. The coronary flow reserve also begins to reduce only at around 40 to 50% of the diametric stenosis, but it falls below 2 whenever there is 75 to 80% of the occlusion, which indicates a severe stenosis. When such cases are seen, it usually leads to myocardial ischemia. But when there is a sudden large displacement of the plaque or a clot formed in the vessel, it travels distally and blocks the blood flow. As a result, since it's an acute event, there is no time to adapt or no time for the collaterals to develop. Patient usually suffers myocardial infarction. The site and the severity depends on which blood vessel is occluded and how acute the condition is and how severe the stenosis is. Since we have just survived a big pandemic such as COVID-19, I would just like to add a slide on the effect of the COVID pandemic on the coronary circulation. In 2022, there was a study conducted on 23 post-acute sequelae of COVID-19 cardiovascular syndrome patients, which showed that there was a 20% decrease in ability to dilate the coronary blood vessels in such patients. This was mainly attributed to the microvascular dysfunction caused by damaged endothelium. As I told you, like whenever the endothelium is damaged or there is a microvascular dysfunction, it causes release of endothelin and thromboxane, which are potent vasoconstrictors. As a result, they won't be able to dilate as per the stress. It served as a marker for poor prognosis and it was associated with higher risk of adverse cardiovascular events. Since we have known what is the anatomy, physiology, and pathophysiology, whenever we encounter a patient with a coronary artery disease, we now know what are the main goals of the anesthetist. For such patients or like normal individuals, we have to maintain a proper coronary blood flow. We have to avoid tachycardia. We have to avoid hypertension. We have to maintain the preload and decreased systemic vascular resistance, that is afterload. In order to conclude, I would like to conclude by telling that myocardium has a continuous supply of oxygen. Since its extraction is around 80% at rest and it cannot depend on anaerobic respiration, the demand has to be met by increasing the coronary flow. Whenever such demand is not met, it leads to myocardial ischemia. So, in our detailed understanding of the coronary circulation, anatomy, physiology, and pathophysiology, has and will allow us clinicians to tackle the issues related to stress induced by anesthesia and surgery and prevent perioperative mortality and morbidity. These are my references. Thank you.